A stoma is a surgically created hole on the stomach, which helps our patient to excrete, to pass through. It can be stool, it can be urine, it can be sputum. All those are stomas.
And just note all these conditions come up, most probably 90% because of cancers.
Not really.
Or trauma.
There are so many things that can make you get a stoma. Because it is trauma. Trauma can make you get a stoma. Cancer. Other conditions like diverticulosis, which is an infection.
Infection of the larynx.
There are some conditions like volvulus, where the intestines just twists or gets interception, where it gets into the other one. So there are obstruction of maybe fecal impact. Yes. So there are many, and in children we have so many congenital issues, like
when there is
ALM, where there is no anal opening. So they have to go through this process, and they get a colostomy so that they can pass through as the other process of treating the child continues. So the colostomy is not for a certain age. It is from the old, the middle age to the neonates.
Anything can happen to you at any time.
So don't see a patient with a stoma and think,
you are immune.
You are not.
Never stigmatize.
Yes.
So apart from the colostomy bags and everything, how do you take care of the stomach?
Okay, it is simple. The most important thing is you settle the patient psychologically. That is, the psychological part is very key. Because if the patient is not settled psychologically, they will not take care of their stomach. You'll go there and they will look like this.
It's like Miyako.
It's yours. And we have experienced that in the ward. But if you work with the patient step by step, and if you are able to capture this patient pre-operatively, although most of them, they come as an emergency and they find themselves with a stoma. But those you capture pre-operatively, they do very well even post-operatively. So we do pre-counseling. You take this patient step by step, from the diagnosis to what is going to happen to how to take care of the stomach. So when it comes to stomach care, the most important thing here is integrity of the skin around the stomach, because that is where the bag will hold. If you don't have skin integrity, where that the skin has been excoriated because of the effluent which is coming from the stomach, the patient will go to depression because they will be leaking now and then. So skin care, very key. Then you educate the patient on how to self-care. In stomach care, you should know the measurement of your stomach, so that when you're cutting your bag, you don't get excessive or smaller. If you cut small, it stagnates the stomach. If you cut excessive, the area left between the stomach and the bag becomes excoriated. It is eroded by the content. Yes. So you teach them how to do that. You teach them how to clean their skin, how to cut the bag, how to apply the bag, how to empty it, how to dispose it. Yes.
Wow.
Yes.
And when all that is done, I think the
They
patient
live a very comfortable life.
Okay.
Mostly I even tell them that you are not alone in this. And you give them examples of high-profile people who have ever had a stomach. Yes.
But the good thing is, even most of the stomachs are closed later when there is healing, unless there was a major reason as to why it has to be permanent.
They are either temporary or permanent.
Yes.
Most of the permanent stomas are the ones for patients who have cancer, tumors, that they cannot be excised They cannot be touched. So we do a diversion stoma because there's blockage already. Or a patient who had like anolectal cancer and they did the resection of that part from the sigmoid downward, since they will also affect the sphincters. But a stoma that the sphincters are not affected, most likely it will be reversed and the patient will continue with their normal life.
It's such a heavy career line that not so many people are aware of, and especially if we've not done much of surgery. After stoma, we have continence care. What is continence care? I've never thought about that.
Continence care is where a patient have incontinence and you restore continence.
Incontinence, you restore continence.
Yes, because this person is passing stool or urine involuntarily. But now you want to contain it.
Is fistula part of the continence?
Fistula is not part of the continence. If they are in the urinary gynae areas,
it's not
it might be an incontinence because it will be making the patient to pass stool or urine involuntarily through the fistula. Yes. But mostly we categorize the fistulas with the stomas.
I see.
Yes, because the care of fistulas is almost with the stoma. Yes.
So how do you handle incontinences to turn to continence?
There are different ways of doing that, and also it depends on what is causing this incontinence. Incontinence, most of our reproductive age mothers, if you assess them well, they will have incontinence. One, most people think that incontinence is only when you are wetting the bed or you are passing through in bed. But incontinence is not just like when you cough and you sip urine.
That's incontinence.
That is incontinence.
When you laugh
and you sip urine, that is incontinence. When you go near the toilet and feel if I meet somebody there, it is going to pour out, that is incontinence.
Hey, then most of us are incontinent.
Yes.
What do you do?
So when it comes to those simple things that people don't think it's part of incontinence, it is easy because most of them, they are blocked by laxity of our muscles. During productive time. And most of us mothers, after giving birth, we don't do exercises. So the simple one, like we have stress incontinence, involuntary incontinence, mixed incontinence, urge incontinence. Those are the simple ones. I was telling you that when you cough, when you rush to the toilet and you feel that if I find somebody there, it will not be well with me.
Even before you get there.
Yes, those can be corrected by exercises. The pelvic floor exercise. Yes.
So you teach the patient.
You teach the patient how to control it. So in this profession, in this specialty, it is a multifaceted and a multidisciplinary profession. Because I'll need to send my patient to a physiotherapist. I'll need a nutritionist to come in here when it comes to like something we call the wound care. I'll need a surgeon, a plastic surgeon to go and cross that wound. So it is a multidisciplinary area. So most of these patients, like in our setup, you don't take everything. You distribute to the appropriate department. Now, if it is an incontinence that we cannot heal, we teach these people how to live comfortable with incontinence products. There are some people who don't know that there is a diaper for an adult. Yes, there are people who don't know that there's a diaper you can put on if you have that problem that is not getting solved, and you continue with your normal life. You go to the shopping center, you do your things, you go to church and come back home.
Comes out.
So most of the people, when they get this problem of incontinence, they are confined in home. They don't go because the only thing they know is maybe take a lasso and make it into pieces so that you can put it as a pad.
Or they take salt
Yes, excretion. But there are so many good products outside there that you can live with comfortably, both for men and for ladies.
Also men get incontinence.
Yes, they do. Especially those who have prostate problems. Yeah.
Okay. At least for them, it is secondary to this, but for women, it's childbearing.
Yeah.
Especially normal deliveries.
Yes.
Wow, that's about incontinence.
Yes.
Let's talk about wound care. Wound care is a specialty that is so big and you can never exhaust. I have worked in wound areas. Sometimes you don't know what products to use where. And I wish people doing products for wound care can come out and educate people more.
Yes. Wound care is a very complex line of nursing.
It is.
And wound care is not just seeing that hole, the wound. Wound care is seeing the patient as a whole. Because I was told you, wound care is a multidisciplinary team kind of line, where you see the patient as in health-wise, the nutritional status of that patient. Does this patient have any other problem, any other conditions that will interfere with the wound care? What type of a wound are you dealing with? Which kind of product am I supposed to use to improve the healing of this wound?
So let me come from the layman perspective. Any wound, it's not healing, you're told, apply honey.
Yes.
It's not healing, you are told, get maggots. You've seen the maggots being used for wound dressing.
Yes.
When all these things have failed, now we come to the general nursing care of normal saline, swab, clean, cover.
Yes.
Then it's not healing.
So in wound healing, there are 3 objectives. One is pain control.
Which is never put.
Yes. Pain control, infection control, and the process of wound healing. So you must have a comprehensive knowledge on wound care for you to make a wound heal. It's not just a matter of cleaning and putting a gauze. No. It is more than that. So if you get to know how to do appropriate wound assessment, you'll be able to treat any kind of wound. Because wound talks to us.
Oh, they do?
Yes. They tell you what they want. And you cannot have one dressing for all stages of wound healing.
That's what sometimes.
And that is where you are talking about just cleaning and putting a gauze.
So that's 80% of.
Yes. But each stage of wound healing
is managed.
It is managed different.
Oh God.
So if you are told by somebody, go and buy a carton of this product, don't do it. Because I'm supposed to do an evaluation of that wound. A comprehensive evaluation every 2 weeks. After using a product for 2 weeks, I should evaluate it. So is it improving this wound? Or is it worsening? Yes.
This dressing before 2 weeks comprehensive review, you're supposed to use one product consistently.
It is important to use one product for some days.
Okay.
So that you can see whether it is improving your wound. But if today I use 2 less dressing today, tomorrow I use a dressing with silver, the next day I use a dressing with copper, and the next day I use a plain dressing.
See, we are told.
I will not be able to assess the progress of that wound.
We have been doing it wrong, guys. We have been doing it wrong.
Yes.
We need, I don't know what we need to do when it comes to home care. I'm not concerned about tertiary hospitals, which manages around 5% of the population. I'm not bothered because these products are there, this knowledge is there, and if it's not there, we have various people who can support you. I'm worried about those patients
in the mashinani.
Yes, who are having diabetic foot, who are having burns, who are having sickle cell wounds, who are having just wounds that are very persistent. Mm-hmm. I wish they can be able to visit the nearest home specialist. I don't know if there are many in this country.
We are not so many. Mm-hmm. Because by the time the program I said, which was in Aga Khan, was ending, we had a total of 53 trained nurses, 49 from Kenya. So in Nairobi, we were privileged because we had some people from KNH, we were 9. There was some people from Aga Khan, Mata Hospital. We had somebody from Isiolo. We had somebody from Kisumu. We had somebody from Homa Bay, Nyeri, Machakos, Melo, and I think those are the ones I can remember. So remember, and Maridi and Mombasa, Kilifi, we had somebody. But that is one person in a county.
And even if you have this one person, the resources may not be available.
Yeah.
And again, in healthcare, when you don't practice something for a while, it fades off.
It fades off, yeah.
It fades off. Wow, that's a very good gap. Those people dealing with HRH in Kenya, kindly, if we can have this training rolled out again, now without donors. Now, the people who are trained, I don't know whether you come together and try to do it all around and train the others.
Already we have a program.
Okay.
In KNH School of Nursing.
Oh, please tell them.
Yes, we have a program in KNH School of Nursing for Stoma, wound, and Incontinence, where we are training nurses, not only nurses, clinicians. You can be a nurse, a nutritionist, physiotherapist, doctor, CEO. We are training them for 3 months. Mm-hmm. And I think at the moment I have the 7th cohort.
Wow, awesome.
Since we started in 2021 January, and up to now we are training.
You see, the program is rolled out. I know maybe they will ask about fee. Please comment down below if you want to know more about this course. We can get Mary come back again and give us more content and educate us on what to do. I just want to ask you a few things that will help us know Mary better. So today, if somebody will ask you, who do you look up to in this career that you are in, who will that be?
That's a difficult
it will be you.
Question, because I've encountered so many people who are helpful in this training. And I don't know whether I can say a specific person because there are so many that have inspired me in nursing and have made me that passion to grow. Because today, if you tell me to stop being a nurse,
I don't know what you will be.
I don't know what I will be.
Wow.
Because nursing is in me.
It's in your blood.
In my blood.
I was almost asking again, if you are not a nurse, what will you be?
But another group that I'm so much concerned about is the elderly. I feel I should do something for the elderly. And I've already started something back at home. Once in a while, I just go there with a small package. We share life together. But the most important thing I like is when I see this old generation coming together, talking to each other. You know, when they are individual, they are just at their own place, lonely. But when you give them that 30 minutes with somebody of their age, and you just sit at the corner,
they remember themselves.
I don't know. You feel you have done something for them.
Wow.
Even if you don't give them anything, that time, giving them that time together, bringing them together to church, to love, to remember those days they could walk around, go to the shopping, go to the garden, and they would say, Mama Fran, you go kwa champa and all that. That one makes me happy.
Exactly.
Yes.
Wow.
Yeah.
So give us one experience in your wound care, stomach care, incontinence care that really made you very sad.
There's this young man, a Muslim, who was my patient the initial times when we opened the wound care clinic. We really worked on that young man, but the wound could not improve. It could improve. He went for several theater procedures. It was on the leg, and they kept excising. And after some time, the problem came back. Finally, this boy decided, the relative, I think they decided to look for options of treatment. Of late, I've not talked with the uncle. He's the one who used to bring this boy, but he told me he wants to look for alternative. Whether it is tradition, healing, taking the boy out of the country, like that, but I've not followed up after that. But I was so sad because he was a lovely young man who had a lot of vision and passion of the future. So, and he was in his high school program. Yeah. Actually, if you don't have the heart for woods, you cannot work as a wood care nurse. You see some woods that have been there for years. It's not healing. But with the new technique of wood healing, it is just simple. Assess your wood, and it talks to you. When you do that, you assess the wood. There are different parameters. The wood talks to you because it tells you what it needs.
Kindly go to her school and the wood language.
So there's a way we assess. We have parameters. Like now we use the word time, acrom time. T is for tissue. You have to assess the tissues. I is for infection and inflammation. M is for moisture. And E is the edges. How are the edges? And the edges, there are some parameters of assessing the end.
But you find a wound is just red every month.
Yes. You find a wood is red and you think, I've done it. But it is not moving.
Imagine.
There's something we call biofilm. Biofilm is a colony of microorganisms, different microorganisms. They have made a cocoon. And breaking it is now the issue.
It causes the redness.
It will be red but shiny. Have you noticed that?
It is shiny.
That shiny part of it is a layer of microorganisms that have joined together.
And they have sat there.
And breaking them is not easy.
Okay.
So you'll find your wood is nice, red.
And you think it's healing.
And it is not contracting.
It's not contracting.
It is just stagnant.
And it's moist.
The other thing is, what kind of product are you using on that wood?
Normal saline goes and cover.
And inadine. Inadine stagnates the wood. It's a good antimicrobial. It's nice. But
there are homes for it.
The advantage over disadvantage, the disadvantage outweighs it. Because it stagnates the wood, it destroys the viable tissue. So you will see the wood is nice, but it's not moving. It is collusive.
Wound care needs patience though.
Yeah.
For you to be a wound care person.
You have to be very patient, because wound care is not the way you give a patient a Panadol and the pain is over.
So if you're like me, please don't go to this field. If you are not a patient person, very patiently waiting on the Lord, don't touch this career.
Yeah.
You need to be very patient and very critical assessor of every single activity.
Yeah.
I want to pose a question to you. This will be a final one.
Yes.
If today Nakumicha resigns and the government appoints Mary as the head of health in the country, where will your focus be on?
Generally, I would focus on the well-being of the patient and the well-being of the carer, that is the nurses and other multidisciplinaries that are there. But having been a wound care nurse and seeing the output of appropriate wound care, I would advise the nursing program through the Nursing Council to bring this topic as part of the training so that all nurses, when they are coming from the college, they can be able to handle the most complex ward comfortably on an easy way because they are knowledgeable.
You know what I've understood in a nutshell from you is review the nursing training curriculum.
Yes.
Review the nursing training curriculum,
Yeah.
develop adequate human resource.
If not that, we have a bigger program than we are having. At the moment, we are having a certificate level where we are taking people 3 months, but we are on the process of thinking of a diploma training or maybe beyond diploma training. Yes.
Or it becomes a postgraduate
Yeah.
diploma.
Yeah.
Wow. Thank you, Mary, for gracing Health Focus. And if need be, we shall have you here with various organizations that are producing products for wound care, and as nurses have no idea where to use it on.
I think that is a very challenging area.
Yes.
Because you'll find that an institution has provided the wound care.
Yes.
They are in store.
Yes.
They are even out of store to the clinical area.
Yes.
But the people in the clinical area don't know where to use what.
That's our next discussion. Trust you me, we shall be here with all these products and we shall be talking about them. That is all we have for today. This is Health Focus, and thank you for watching to the end. Let's see you again next week.